Welcome to the deep dive. Our mission today, well, it's to take a really focused look into the world of childhood mental health. We're synthesizing the key info from Chapter 11 in Varcarolis' Foundations of Psychiatric Mental Health Nursing. It covers childhood and neurodevelopmental disorders.
Right. It's about understanding the unique challenges for our youngest patients and the nursing principles we need.
Absolutely. And straight off the bat, the statistics are, frankly, kind of staggering.
They really are.
We tend to think of mental illness as an adult issue,
Yeah.
right? But the research shows over half of all lifetime psychiatric cases actually start before age 14,
It's a huge figure, such an early onset.
which feels like a massive failure somewhere along the line. And you've got about 20% of kids and adolescents affected each year.
Yeah, and the ripple effects on their school, their social lives, family stability, it's just devastating.
It really is.
And this points to a big challenge in practice. Diagnosing young kids is, well, it's tough.
Why is that?
A few reasons. They have limited language,
Huh?
to describe what they're feeling inside. Plus, their brains and minds are changing so rapidly.
So what looks like a problem 1 month might just be normal development the next.
Exactly. Or a lag. It's hard to tell sometimes. And this often leads clinicians and parents into this wait-and-see trap.
Which sounds dangerous if time is critical.
It is, because you delay potentially vital early intervention. On top of that, you have massive systemic barriers.
Like what?
Well, there's no real consensus on universal screening for kids. Care coordination is often a mess, fragmented.
Okay.
And then there are the resource gaps, finding specialized providers, the long waits, the cost. It's just incredibly difficult for families.
So the need is clearly immense, but getting help is complicated. Okay, let's unpack this. Starting with the factors that put children at risk.
Right. You have to begin with the biology. Genetics definitely play a part. There's clear vulnerability for many disorders.
But it's not just genes, right?
No, not destiny. Things like resilience or intelligence can limit whether a disorder actually develops. And the neurobiological changes happening are critical.
You mean how the brain is developing?
Precisely. The brain is constantly reorganizing during childhood and adolescence. For instance, the number of connections, the synapses, they actually peak around age 5.
Peak. Then what?
Then they decline. It's a process called pruning, getting rid of unused connections to make the brain more efficient.
Okay.
And at the same time, myelination is increasing. That's like insulating the wires, making nerve signals travel faster.
So the brain gets faster and more efficient.
Yes, but here's the crucial bit. The frontal and prefrontal cortex, the parts responsible for executive functions like impulse control, planning, emotional regulation, they mature last.
Way later.
Well into late adolescence, sometimes early adulthood. And that biological fact explains a lot about why younger kids and teens often struggle with frustration and managing emotions.
Ah, okay. The hardware for self-control just isn't fully installed yet. That makes total sense. So if we layer cognitive factors on that developing biology, we get to temperament. How do we define that?
Temperament is essentially the child's usual style, their mood, their attitude, how they react and cope with the world. It's sort of their baseline way of being.
But some kids are just naturally more intense or slow to warm up, right?
Yeah.
How do we know if it's just temperament versus, like, a sign of a problem?
That really depends on the environment. The absolutely critical concept here is the fit.
The fit.
The fit between the child's temperament and the parent's temperament and parenting style.
Okay, so if they clash?
If there's a mismatch, say a very active, spontaneous child with a very rigid, stressed parent who can't adapt, that poor fit is a major risk factor
For what?
for insecure attachment, developmental issues, and yeah, a significantly higher risk of developing psychiatric disorders later on.
Wow. Okay, so fit is key.
Yeah.
But what about the kids who thrive despite challenges?
Resilience.
Yes, resilience. The ability to bounce back, to recover quickly from stress or difficulty.
What does a resilient child look like? What are the characteristics? Well, they tend to be adaptable. They can usually maintain pretty good problem-solving skills even when stressed. They often have good social intelligence. And critically, they have this ability to form nurturing relationships with other supportive adults, maybe a teacher, a grandparent, a coach, especially if things at home are chaotic.
So they can find support elsewhere.
Right, and they can distance themselves emotionally from the chaos around them. These are the protective factors we really want to spot and build on.
Okay, now, environmental trauma. This seems huge. The ACEs study adverse childhood experiences.
Yes, the CDC Kaiser Permanente study, its findings were and are profound.
Tell us about ACEs. What are they?
They include things like physical, sexual, or emotional abuse, also neglect, And household challenges like substance abuse, mental illness in the family, domestic violence, parental separation, incarceration.
And neglect. You mentioned that's the most common.
It is, shockingly so. Roughly 75% of child maltreatment victims in the U.S. experience neglect. It often flies under the radar compared to active abuse. 75%, that's sobering. And the study linked these experiences to adult problems.
Directly. There's a clear dose-response relationship. The more ACEs someone experienced in childhood, the higher their risk for serious issues later in life.
Like what kind of issues?
Alcoholism, drug use, poor performance at work or school, major depression, even suicide attempts. The connection is undeniable.
So that 75% neglect figure, it means nurses really need to think about abuse differently, right? It's not always bruises.
Exactly. It's often about that chronic lack of response, emotional deprivation, that literally impacts how the brain develops. And during assessment, we also have to be mindful of cultural context.
Also,
Well, a child's age, ethnicity, gender, family background, all these things shape how problems present and what interventions will be appropriate. We have to check our own biases constantly.
you're right. Culturally responsive care is essential. Okay, so we have biology, temperament, environment, ECEs. It's complex. How do psychiatric nurses actually gather all this information effectively, especially with kids? Let's move into the nursing assessment. Yeah, assessment is definitely complex with children and adolescents. A big part of the challenge is translating what parents or caregivers tell you.
Why? Are they unreliable?
Not necessarily unreliable, but their perspectives can be shaped by their own stress, their own history, maybe even denial sometimes. So you need a structured approach.
What goes into a comprehensive assessment?
You need the history of present illness, of course, a really detailed developmental history hitting milestones, the quality of attachment, how they play.
Size important.
Crucial. We'll come back to that. You also need medical history, family history. Psychiatric issues in the family are a key risk factor. And then a mental status exam.
But adapted for kids, right?
Absolutely adapted for their developmental stage, and a neurological assessment, too.
Since direct questioning can be hard, especially with younger kids, how do you actually collect this data?
Ideally, from multiple sources. Parents, yes, but also teachers, other caregivers if possible. Getting different perspectives is key.
And are there specific tools you use?
Yes, there are structured tools described in the text, the genogram, for example.
What's that?
It's basically a family tree diagram, but it maps out relationships, patterns, significant life events across generations. Really useful for seeing family dynamics.
Okay. What else?
The Denver Second Developmental Screening Test is another one. It checks social development, fine and gross motor skills, and language. Gives you objective data points. But honestly, a lot hinges on nonverbal techniques during the interview itself. Play therapy. It's often called the work of childhood for a reason.
How does play help therapeutically?
Especially for trauma. Difficult experiences often get kind of stuck in the nonverbal emotional parts of the brain. Play allows kids to act out those experiences using toys, drawings.
And that helps process it.
Exactly.
Yeah.
It helps move those memories and feelings towards the verbal thinking parts of the brain, the frontal lobes, where they can be understood and integrated. Therapeutic games, drawing, even puppets. They're all ways to access a child's inner world when words fail.
That's fascinating. Okay, so you've gathered the assessment data. Now, intervention. What's the guiding philosophy, especially around safety?
The absolute core principle is the principle of least restrictive intervention.
Meaning?
Meaning, you always start with the least intrusive method possible to manage behavior and ensure safety. It's a hierarchy.
Can you walk us through it?
Sure. You start with talking, verbal de-escalation, then maybe offering a PRN medication if appropriate to help the child regain control internally.
Okay, what if that doesn't work?
Then you might move to a timeout, perhaps in a designated quiet room or a sensory room designed to be calming.
And physical restraint or seclusion?
That is the absolute last resort, only used for behavior that poses an imminent danger to the child or others. It should be rare.
And there are strict rules around that.
Extremely strict. It requires immediate authorization, like from a physician or licensed independent practitioner. Constant one-on-one monitoring by trained staff is mandatory, checking vital signs, hydration, comfort, ensuring circulation isn't compromised.
To prevent harm, like asphyxiation.
Exactly. Safety is paramount. And after any restraint or seclusion, there's required documentation and a debriefing process for the child and the staff. The system takes it very seriously.
Good. That tiered approach sounds vital for maintaining respect and safety. What other kinds of therapies are used beyond managing immediate crises?
Oh, lots. Behavioral interventions are common, often using things like point systems or sticker charts to reward positive behaviors.
Hmm.
There's bibliotherapy using specific stories or books to help kids understand and cope with issues. Expressive arts therapy taps into creativity, drawing, painting, music as an outlet.
Journaling for older kids.
Yes, journaling can be very effective for adolescents. Music therapy is another powerful tool. And crucially, family intervention.
Because the family system is key.
Absolutely. You almost always need to involve the family. These are often chronic conditions, and the family needs support and strategies to manage things long term.
Okay, that makes sense. Let's use our final segment to dive deeper into 3 specific neurodevelopmental disorders that nurses frequently encounter: ID, ASD, and ADHD.
Sounds good. These three account for a lot of the work in child and adolescent mental health.
Let's start with intellectual disability, or ID.
Okay. ID is characterized by deficits that show up during childhood in three main areas.
What are they?
First, intellectual functioning. This includes reasoning, problem solving, learning ability. Second, social functioning things like communication, understanding social rules, interpreting cues. And third, daily functioning practical skills like self-care, managing money, school or work tasks, living independently.
And the nursing approach.
It really needs to be strength-based. Focus on what the individual can do, their abilities and interests, not just the deficits. The goals are usually very individualized, often focused on promoting independence as much as possible and planning for long-term transitions, maybe to supervised living or supported employment.
Got it. Okay, next, autism spectrum disorder, ASD.
Right. ASD is primarily a disorder affecting social relatedness and communication skills. You typically see signs in the first few years of life.
What are the core features?
Deficits in social interaction and communication are key. But you also see restricted, repetitive patterns of behavior, interests, or activities. This could be repetitive movements like hand flapping, an intense obsessive interest in a specific topic like trains or dinosaurs, or an insistence on sameness, extreme distress at small changes in routine, and often unusual reactions to sensory input, either being overly sensitive or undersensitive to sounds, lights, textures, pain.
But it's a spectrum, right? Severity varies.
Exactly. It's classified by levels of support needed. Level 1 requires support, Level 2 requires substantial support, and Level 3 requires very substantial support. Individuals at this level might be nonverbal or have severe difficulties with daily living.
What works for intervention?
Early intervention is absolutely crucial for ASD. The earlier you start, the better the outcomes tend to be. Applied behavior analysis, or ABA, has the strongest evidence base. Yes, including specific models like Early Intensive Behavioral Intervention, EIBI, or the Early Start Denver model, ESDM. They focus on teaching social, communication, and adaptive skills.
What about medications?
Meds don't treat the core symptoms of ASD, but they can help with associated problems. Second-generation antipsychotics like risperidone or aripiprazole are sometimes used for severe agitation or irritability. SSRIs might help with anxiety or mood issues, and stimulants might be used if there's co-occurring hyperactivity.
Okay. And the third big one, attention deficit hyperactivity disorder, ADHD.
ADHD. This involves having an inappropriate degree of inattention, impulsiveness, and oncodor hyperactivity for the child's developmental level.
And it has to be causing problems.
Yes, significant problems. And the symptoms need to be present in at least 2 settings, like both at home and at school, and typically appear before age 12.
What kind of problems does it cause?
Kids with ADHD often have low frustration tolerance. Their moods can be quite labile. They struggle in school, have difficulty with peers. It really impacts their functioning and self-esteem.
And the treatment is kind of paradoxical. Using stimulants.
It seems paradoxical, yes. Stimulant medications like methylphenidate Ritalin is a common brand name, or mixed amphetamine salts like Adderall are actually the first-line treatment.
And they work how?
They actually stimulate parts of the brain involved in attention and impulse control, helping the person focus better. They are very effective for many kids.
But there are risks.
Definitely. They are controlled substances, so there's potential for misuse or diversion. Side effects like insomnia or decreased appetite are common, so nurses need to screen carefully, especially for any history of substance use or tics before these meds are started.
Are there non-stimulant options?
Yes. If stimulants aren't suitable, maybe due to side effects, anxiety, iatrogenics, or substance use risk, then non-stimulants are used. Atomoxetine, brand name Stradera, is one, or the alpha-2 adrenergic agonists like guanfacine and Intuniv, or clonidine, Cafe.
Okay, that covers the big three.
Mm.
But there are other neurodevelopmental disorders mentioned in the chapter too, right?
Definitely worth touching on briefly.
Like communication disorder.
Yes. This includes language disorder, difficulty understanding or using language. It's important to note that receptive impairment, trouble understanding language, generally has a poorer prognosis than expressive impairment, just trouble speaking.
Okay.
There's also speech sound disorder problems, pronouncing sounds correctly, childhood onset fluency disorder, which is stuttering, and social or pragmatic communication disorder, difficulty with the social use of language, like understanding turn-taking or nuances in conversation.
And early intervention is key for these two.
Absolutely. Often through speech therapy services accessed via schools under the Individuals with Disabilities Education Act, or IDEA.
Right. What about motor disorders?
You have developmental coordination disorder, clumsiness basically, significant problems with fine or gross motor skills like tying shoes, catching a ball, handwriting. Physical therapy or occupational therapy is the main treatment.
Okay.
Then stereotypic movement disorder. This involves repetitive, seemingly driven but purposeless movements, hand-waving, body rocking, maybe even headbanging.
Sounds concerning.
It can be. Safety is the priority, especially with headbanging. Habit reversal training can sometimes help.
And tic disorders.
Tics are sudden, rapid, recurrent, non-rhythmic movements or vocalizations. They range from provisional tic disorder lasting less than a year to persistent motor or vocal tic disorder lasting longer.
And Tourette's.
Tourette's disorder is diagnosed when someone has multiple motor tics and at least one vocal tic present for over a year, starting before age 18.
The media often portrays Tourette's with swearing tics.
Right.
Upperlalia.
Yes, but clinically that's actually quite rare. Fewer than 10% of people with Tourette's have coprolalia. Most tics are simpler: eye blinking, throat clearing, sniffing, shoulder shrugging.
Good to clarify. How are tics treated?
Behavioral therapies are often first line, particularly CBIT, Comprehensive Behavioral Intervention for tics. It teaches awareness and competing responses. Medications are used for more severe cases.
Okay, one more category. Specific learning disorder.
Right. This is diagnosed usually during school years when a child has persistent difficulties learning key academic skills, reading, writing, or math, despite having normal intelligence and adequate instruction.
So dyslexia, dyscalculia.
Exactly. Dyslexia is an impairment in reading, dyscalculia in math, dysgraphia in written expression. These kids need specialized educational support, usually outlined in an individualized education program, or IEP.
Makes sense. So wrapping this all together, what's the big picture takeaway for nurses working with these kids?
I think the main thing is that treatment is almost always multimodal. It's rarely just medication or just therapy. It usually involves a combination: meds, psychological therapies like CBT or play therapy, behavioral plans, educational support. And because these are typically chronic conditions, lasting years or even a lifetime, ongoing, comprehensive family involvement and support are absolutely critical for success. The nurse often acts as a key advocate, educator, and coordinator for the child and the family. That advocacy role is paramount.
That focus on chronic care and family support is so important. We touched on how conditions like ADHD and ASD often persist into adulthood, requiring lifelong support. But the structured school supports, like under IDEA, they eventually end.
Right. That transition point is a major challenge.
So here's something for you, our listeners, to think about. What does effective, comprehensive, long-term planning look like for individuals with neurodevelopmental disorders as they transition out of the structured academic world and into adult life? And what new or expanded roles might nursing need to play to help bridge that significant gap effectively?
That's a critical coffin for the future of care.
It really is. Thank you so much for joining us for this deep dive today.